Hi, everyone. I am delighted to be joined today by Professor Alan Su, a cardiothoracic surgeon working at Galway University Hospital. Thanks so much, Alan, for taking the time out of your busy day to join us for this episode of Croí Connects with the Experts to answer some questions about heart valve disease. And I suppose just to set the scene for our audience, valve disease is typically associated with aging. 1 in 10 75-year-olds in Ireland today are living with valve disease. Ireland's ageing population is leading to an increased prevalence of heart valve disease. It is estimated that across Europe, the number of people living with heart valve disease will double by 2040 and triple by 2060. So that's pretty staggering. Heart valve disease has been described as the next cardiac epidemic. However, it is not all bad news, as we'll hear from you today, that although heart valve disease is common, it is indeed serious. It is important to stress that with early detection, early diagnosis, and management, it is eminently treatable. So, Alan, this is going to be a fairly quick fire round because I know you need to get back to work. So let's start with the simple basic question: what is heart valve disease?
So, Annie, thank you first of all for having me. Heart valve disease, simply put, first of all, you need to understand what a heart valve is. I always like to describe to my patient that basically your heart is a big piece of muscle that pumps blood around. Uh, within the heart itself, there are 4 valves. We usually concentrate on mainly 1 or 2 of them because the other 2 don't really give us much trouble. And the valves are essentially they're like I like to describe to my patients the valves on the radiator to allow one-way flow of the blood flow. So it allows blood to flow only one way so that it won't go back and stress the heart. And valve disease essentially means that there's something wrong with the valve. Irish have a very good term called banjax. I like to use it all the time. Essentially, the valve is not working. Now, there are 2 main mechanisms. Either the valve is being blocked, called stenosis, or the valve is not working and the blood is leaking back into the heart, called regurgitation. Essentially, the pathology, as in like the way that caused that to happen, can be very similar. Based a lot of time could be just purely aging, but purely just degeneration, and that's what essentially heart valve is: either blocked valve or leaky valve that disturb the one-way flow of the blood circulation system and hence causing trouble to your heart.
Excellent. And what is the most common type of heart valve disease?
So the most common type of heart valve disease in the developing world these days is called aortic stenosis. Essentially, the aortic valve is the valve that's between the heart and this big pipe called the aorta that transport blood to the rest of your body. The valve is in between. And aortic stenosis essentially means that the valve is so blocked off and it's kind of you develop little calcium debris on it that doesn't allow it to function properly. So the valve is very stiff. If you can imagine, like the hinges on a door, that the door doesn't open and close very well. So not as many people can squeeze in and out. So in and out, if the door is open fully, you can let 10 people out. Whereas if the door can only open 30 degrees or 10 degrees, you can only allow one people out. So that's essentially what aortic stenosis literally means.
And why is this? Is this lifestyle related?
No, I'd like to say there is, but it is purely related to aging. There are 2 types of aortic stenosis. We call it a degenerative one or a congenital one. So there are the most common type of aortic stenosis are the degenerative aortic stenosis. Essentially, unfortunately, part of aging, we are all going to get it at some stage in life. If you look at a lot of the 80 years old out there, the prevalence is up to like 5-10% or so. If you talk about 90-year-old, it's probably up to like 30-40%. So it is part of aging. A lot of people get it a lot younger. We commonly see them from like 60-65 years old onwards. Now then there are the other kind of congenital aortic stenosis called congenital aortic stenosis, and those are the far extremes are the one that babies who are born with that, but we are not covering that for now time being.
Okay. Yeah.
But there are a subgroup of patients whereby their valve is congenitally or born slightly abnormal. So instead of having 3 flaps that looks like a Mercedes sign, it only have 2 flaps, and those ones tend to degenerate a lot quicker because of the abnormal flow. So patients like that can develop aortic stenosis as early as in their 30s, 40s, 50s even.
Okay, thank
Yeah.
you. And what is the incidence of heart valve disease in Ireland?
Oh, that's a good question. We don't really have a direct evidence of it, but what I can tell you is that from a surgical perspective, I say the cardiologist will diagnose a lot more. So we classify, see, a lot of people who have valve disease or aortic stenosis, but they really only affect you from a symptoms point of view or a lifestyle point of view, where you get short of breath, you get symptoms, you get dizzy and all the rest when they're really severe. So we see roughly about maybe 100, 200 a year in Galway, with the whole west of Ireland, in the whole country, you're talking about probably about up to 1,000 patients in the whole, where they, uh, but from maybe mild to moderate aortic stenosis to become severe and symptomatic, and these are the ones who require treatment. So you're talking about maybe about 1,000 patients a year that probably will require some form of treatment.
Okay. But the good news is that they're getting managed and they're getting seen once you get to that,
Yes,
point. Yeah.
yes.
And do some people have a higher risk of developing it? So aging is one thing, but within that, then do some people?
Well, then people who have maybe, for example, like blood hypertension, there are some family who are just more prone to it. Now, we believe that it probably does run in the family, but unfortunately, we don't have a gene for it. So in the past, we don't usually kind of say if your family or parents have aortic stenosis, we will not kind of ask you patients to go for screening in the past, but nowadays we call it the congenital bicuspid aortic valve disease. Those patients, since a couple of years ago, both the European Society of Cardiology and Cardiac Surgery and the American Society have recommended family screening. In other words, just going to your GP, have a stethoscope to listen to you. And also the beauty of valve disease is that you don't need a very invasive test to investigate it. All you need is an ultrasound transthoracic, as in ultrasound on your chest, to just have a quick look. So through ultrasound, it's not painful. You have a bit of jelly, a bit cold on your chest, a very quick procedure, 15, 20 minutes, and we know exactly what your valve looks like.
Okay, so just to reiterate that again, go to your
So
GP.
go to your GP, have him checked out, assess your risk factors, have a listen whether you have a murmur or not. So murmur is when the GP put a stethoscope on your chest. If there's any valve disease, 9 out of 10 times you can hear as I say, the disturbance of flow. It comes out as like a rumbling. What instead of hearing the loop, 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 you hear a loop or the flow, abnormal flow kind of sound, and that's we call it a murmur. We classify them to a lot of different degree, but that's just jargon. So as long as your GP will hear that murmur, he or she, I'm sure, would refer you to a more specialized investigation called a transthoracic echocardiogram. And echocardiogram is an ultrasound procedure, non-painful, quick jelly, quick look on a quick probe onto your chest, about 15 minutes, and we know exactly what your heart looks like, what your valve looks like.
So this is something that anybody can do if they're concerned that it might be something that's in their family. You start with your GP. It's not a big process. Excellent. Great.
So start with your family, or if you have any symptoms. So a lot of patients, unfortunately, the symptoms with valve disease is kind of vague. Most of them, when they become very severe, they get short of breath on exertion. And now some very severe cases get dizziness and they collapse. Obviously, those ones are the ones that will go straight to the hospital anyway, or GP anyway. So that's not our concern. But our concern are the patients who have a little bit of symptoms like shortness of breath on exertion, and most, as you can imagine, 60, 70, 80 years old will probably just put it down to fatigue or lack of fitness and all the rest, whereas they actually have something significant in their chest that needs to be addressed.
Okay, so that comes back to the importance of the aging factor. If you are, so even if you are a fit 65-year-old,
yes,
just you might notice that there's something a little bit askew, or even if not, you should still have your heart listened to.
You should, yeah. It is a very subtle thing. I'll give one example. So the most interesting case that I had very recently is that there are a couple who likes hiking together. So the husband who came to us at our attention. The reason why he actually presented to his GP is that he used to beat his wife in hiking. He can go faster. Suddenly he can't go as fast as his wife. He thought, and his wife would say, "There's something wrong with you. Go and check it out." And he has severe aortic valve disease. We have to replace his valve, and he's back hiking now. He's catching up with his wife now, so to speak.
Excellent. So that's really good, and that's a really good example of people who are fit and healthy and thinking that there's nothing wrong, but actually remembering that it is associated with aging. It can happen to all of us, and it's just a matter of being proactive about it.
Exactly,
yeah, absolutely.
Exactly.
So you were talking there about the more severe symptoms. So what kind of symptoms would require you to call an ambulance or a doctor or get yourself
So if you get dizzy when most of these are related to exertion. So if you think about it, essentially your heart is trying to pump against an obstruction, and the function of the heart is to pump blood with oxygen. So in other words, your body is, when you have severe aortic stenosis, your body is not getting enough oxygen. Now, when you're resting, it's okay because you don't need a lot of it. But when you exert yourself, like doing any bit of exercise or exertion, you need the extra, and you're not getting it. So these patients with severe aortic stenosis will get either short of breath in the very mild sense. Some of them can get so dizzy that they collapse. So when your brain don't get enough oxygen, they will just feel dizzy. It's almost like as if when you're, when you run a marathon or run any, long distance, when you're not used to it, you get that dizzy feeling. Except this persists for a long, long period of time. Now, most of us, when you're first time doing something, you get a bit dizzy and all. That's okay. But if
Yes.
it keeps happening on a regular basis, every time you do exertion, and the type of exertion is getting less and less and less. So, for example, if you are used to walking a mile a day, suddenly you find, hang on a second, I can't do it, and I'm getting dizzy at the end of it. That is not something not right.
Okay, thank you. And how quickly does it progress? So if you're the person the gentleman we were speaking about a little bit
Mm.
earlier, who's hiking with his wife, if he had ignored that, how quickly does it progress?
So, well, from the mild stenosis to the severe stenosis, it actually takes quite a long time. It can take up to 5, 10, 15 years even. But what we know is that once the valve is severely stenotic, and especially if the patients are symptomatic, we know that there is a natural history study we call it back in the 1950s by this guy called Braunwald, a very famous cardiologist in America. Essentially, at that stage, we have no treatment options. All they can do is just watch people and give them some medicine, which doesn't work anyway. And so they looked at how long patients last. What we know is that patients who are symptomatic and has severe aortic stenosis, within 2 years, they will run into big trouble. They will be what we call heart failure, and by that stage, their heart function will deteriorate. Because what happened in the beginning of the aortic stenosis phase is that your heart, much like putting a resistance on any muscle, your heart will hypertrophy or get thicker to compensate for it, to pump against the obstruction. But that, as you can imagine, can only last for so long. We know that within like 2 years at the most, that muscle will start getting tired and fail. That's when it becomes difficult to
Okay.
manage. Yeah. So
So,
we as
so
a group, yeah, we want, and that's why it will tie into the prevention. We want to know as soon as possible to give patients the best chance so that we can start diagnosing. And especially nowadays, there's a lot of treatment options available, no matter
absolutely.
what age you are, and it's getting less and less invasive. So we want to know as early as possible. Yeah.
Excellent. Yeah, so that is positive. And so early detection, early
Yes.
diagnosis. So listen to your heart, I suppose, is the message
Exactly.
here. Back to the diagnosis piece. So you're diagnosed with heart valve disease. How often after that should you be checked? Let's say you don't need an intervention at that particular time.
Okay.
How often should you?
Again, that depends on the severity. Most of the time, if you do go to present, you either in the very moderate or severe phase. Now, if you are severe, we wait for you to become symptoms. We literally will check you up every 2 months, every 3 months. You'll be called back to the specialist cardiologist to have another echo, to have a look, chat with you, and all the rest. We'll be very monitored very, very closely. The ones who have moderate aortic stenosis, we would opt to do an echo every 6 months, a year. Again, depending on the severity. The mild one we do maybe every 2 or 3 years. Those are the ones that we find by chance because of other reason like a lung disease or something like that.
Okay. And if you do need an intervention,
Yes.
what are the options, I guess?
So at the moment, valve replacement is still the treatment of choice, and this can be done either through an open surgery or this new technique called keyhole surgery, whereby called transcatheter aortic valve replacement that we can do through a groin.
Okay. And
Yeah,
this procedure is called, there's an acronym
a
for that?
TAVI, TAVI,
TAVI.
TAVI.
Okay.
Yeah,
So a patient will have a choice between
yes.
surgery and a TAVI.
Yeah,
Perfect.
again, depending on the age of the patient. So there are pro and cons of both technique. Obviously, depends on the patients, depends on the severity and comorbidities, as in like other history or the sickness or whatever. We'll decide. We will try and offer the patient the best treatment of choice. There are some patients that surgery is the obvious choice. There are some patients that TAVI is the obvious choice, and then there are a group of patients where it's kind of gray at the moment. We don't know which is the better one for them. Those ones the patient can choose. Ultimately, the patient can choose their treatment options.
Excellent. I was just going to ask you about that in terms of the patient, to somebody who's watching this, and they're maybe in that the process of making that decision at the moment. So in terms of the shared decision around that between the clinician and
Yes.
the patient and their family, how generally would you arrive at that, the right
Yeah,
option for
so
the patient?
essentially, of course, different technique has different advantage and disadvantages. For example, surgery, the advantage is that the valve we put in is way more durable, but of course, the disadvantage is way more invasive. Whereas the other way, the technique is less invasive, but the valve may not last as long. So we essentially, as a group of doctors, every hospital nowadays have we call it a heart team, a structural heart team, whereby we discuss every single patient who need this kind of intervention, as it affects the lifestyle of the patient, obviously, prognosis and all. So we discuss for every patient what the recommended treatment option. And then what we do is the group of us will bring these patients to a clinic, and we're jointly, now it doesn't happen everywhere, but a lot of hospitals nowadays, we have a structural valve clinic, for example, in Galway, whereby the patient will come to this specialized clinic, and they will see the people who provide these options, all of us, all at one go. We will discuss with you the pros and cons of each treatment, and together we make a decision. And there's
Excellent.
no problem, because everyone is different, every
Yes.
circumstance is different. Some people like a mechanical valve, some people like a biological valve, some people prefer surgery, some people don't prefer surgery or
Yes.
prefer the keyhole. So everyone is different. We make a joint decision together,
Decision. Yes.
preferably with the family as well.
As well, also
Yeah,
because there are other considerations. Obviously, the clinical outcome is
very much
very
so.
important,
Yeah.
but how a person lives their life after
Yes.
that or during that is
Yes.
also something to really consider. And
Yes, very
everybody,
much
as you say,
so.
is
For
different.
us, for me personally, I like to each and every single patient, I like to have the family on board, because while we only see the patient pre-surgery and peri-operative around the surgery time, when the patient goes home, realistically, is the family who looks after them. And when the first couple of weeks is when the family is very important, and to provide the rehabilitation and the care, and also in the longer term to live with the patient. For example, if they have a mechanical valve, the valve clips clicking away, I think the family needs to know about that too. Or they're
Exactly.
taking warfarin and stuff like that.
Absolutely. And one other question on the difference between the surgery and the TAVI. So
Mm.
you are a surgeon, so you
Yes.
perform the actual surgical
Yes.
procedure, but the
Yes.
TAVI piece, that is conducted or performed by a cardiologist.
By a
Right?
cardiologist, yes, yeah,
Yeah.
structural cardio. Now, nowadays it's very how do you say, it's very blurred. Traditionally, yes, surgery is performed by surgeons, and TAVI is performed by we call them the intervention cardiologists who perform procedures much like surgery. It is used to be a very distinct entity, and nowadays that line is fairly blurred. For example, a lot of the more complex TAVI, I will be there just to help. Now, most of the time, hold their hands, but still I will be there. Whereas surgery, a lot of time, if the cases get complicated, where you have to do two things together, I will invite my intervention cardiologist to come in, and either for education, for them to have a look at the valve, or we do it together. And so the lines are getting more and more blurred as we go. We are trying to achieve we call it intervention team, rather than oh yeah, you're a surgeon, you're a cardiologist, you
Excellent.
do this, you do that. We try to do everything as much as possible as a team. This is a new kind of team working thing, and everyone is bringing this on board.
Yeah, excellent. And that speaks very much to looking at the patient, then the whole
Yes.
patient,
Yes.
considering
Yes.
all the things that you need to consider
Yeah.
in terms of them and yourself making this
Exactly.
decision.
Exactly.
Yeah,
Because
absolutely.
nowadays, with more and more options and more choice, one person cannot deliver the whole spectrum of management. And I know we are concentrating on just the intervention bit, whereby it's us surgeons, intervention cardiologists. But when you're treating valve disease, yourself, the prevention people, the diagnostic people. So we on our team, we also have a diagnostician, someone who do the echo very, very well. After surgery, we have a heart failure specialist as well to manage the patient, and then we get that back to people like yourself in Cree who
Yes.
rehab the patient well afterwards. So it's a big team effort that has to come around for each individual patient.
Yes, so that's important. So in the run up to the diagnosis, then the run up to the decision around the treatment, the supports that are available there in terms of getting to
Exactly.
that decision, then there's the actual procedure itself, and then
Yes.
there's after the procedure, there are
Yes.
the supports that are needed for people once they've had the actual intervention and the follow-up and all of
exactly.
that kind of thing. Yeah.
Yeah,
And
exactly.
as you say, at Croí here, we offer a nurse helpline, so that if somebody has had a procedure with yourselves, that they can then make contact with us. But I assume from your perspective, what are the follow-ups on your side for patients who have undergone a procedure once they've
Yeah, so this is what is not is very well known. Most people undergo a procedure like unfortunately open cardiac surgery, especially valve surgery, is not the same as like a hip replacement or other kind of surgery. Once you have an artificial valve in, you forever have an artificial valve in, and we have a responsibility to keep a check on it. Because for two reasons. One is that the valve that we implanted, similar to your own valve, can degenerate and require a relook, reoperation, reintervention, whatever it is, either resurgery or re-TAVI in the future. And also, there's another piece where infection is or prevention of infection is very important. So we have to keep educating people about prevention of infection, because once any valve can get infected, if we do get infected, it's a big deal to re-intervene on them.
Excellent. What do you see in your opinion is the biggest change coming down the line in terms of the intervention at your disposal as a surgeon, as somebody on that intervention team, in terms of technology, that just in terms of blue sky thinking, I suppose, something that you see that might make a huge difference in 10 years' time to people who are diagnosed with heart valve disease?
Yeah, I think well, a couple of pieces there again. I think the how to say, the most people will answer that question by saying, oh yeah, TAVI is the revolution and all the rest, which I don't disagree with. But I think there is still a lot more coming down the line. We are not quite there yet. Everything is becoming less invasive, including surgery, whereby in the past, surgery takes about 3, 4, 5 hours to do. Nowadays, we can do the surgery so quick that we can do it in 2.5 hours, cut smaller. TAVI has revolutionized how invasive the procedure is. But I think the most exciting thing is that finally, we have, because of this condition and this disease, whereby we have not just ourselves coming together as a team, we are involving people like yourself from outside the industry, more importantly, where they have special expertise in terms of management, funding, and all the rest, where they can invest into all the latest research, innovation that can open our mind into different and new ways of treating patients. And that's, to me, is the most exciting thing. For example, in Galway, I think I know of at least about 5 groups at the moment who's trying to develop new techniques and new valves that we can use in the future. That's coming down the line 5 to 10 years, and none of those are possible if not for this valve team and industry help, like much like yourself and all the rest, like from a research funding, fundraise kind of thing. So I think, to me, that's the most, not what we can do currently, but what we can do in the future with all these people coming together.
Absolutely. So it's a societal approach, really. And I think it's important to say as well, and I know you're very much on board with this as well, is the patient being at the center of all of that,
exactly.
because they're ultimately the ones that are going to be living with this. So thank you so much. So to reiterate, what are your 3 key things, let's say, from this chat we've had now? If somebody is looking at this, they've been dabbling with thinking of going to their GP, they're experiencing some of these symptoms, or maybe somebody has just been diagnosed with valve disease and they're waiting to see what the outcome might be, what would your message be?
Well, I only have one message. The message is, don't wait. Go to see your doctor. Go and see someone. Go and see someone. Go and see someone. That's all, realistically, because there's a lot of help out there. Going back 5, 10 years ago, when I was training or when I first started practicing independently, I don't think there's half as much help. And also, when you go to help these days, there are a lot of things we can't do, or you might not be suitable for this, you might not be suitable for that. Nowadays, there's a lot of options. But the key thing is that if we don't know, we can't do nothing about it. We need to know. Yeah. So go to
go
your
to your
GP.
GP.
For whatever reason, I don't think any GP will mind, even if it's it's a false alarm or whatever. But a lot of time, go to your GP, no matter how busy your GP is, just say, have a quick listen to my heart. It's much like having an ambulatory blood pressure cuff. Check it yourself, get someone to check it. You just need to know. You just need to know. Once we know, there's a lot that can be done nowadays.
Can be done.
Yeah.
So common, serious, but definitely treatable.
Yes, very treatable.
Absolutely. Yeah. Thank you so much, Alan, for joining us today. And to everybody who's watching, Thank you for joining. Just to say that if you do have any questions or queries on foot of watching this, please do reach out to Croí's helpline on 091 544 310. Or if it's relating to heart valve disease, you can check out www.croi.ie/valveweek on our webpage. Thanks for joining. See you next time.